Nobody says this clearly enough. The medications prescribed to protect your health after 60, the ones sitting in the pill organizer on your kitchen counter right now, are not automatically safe simply because a doctor wrote the prescription. They are tools, powerful tools with real benefits, but tools that in an aging body operating over months and years can produce effects on the cardiovascular system that the original prescription never accounted for. I want to be precise about what I mean by that. I am not saying your medications are wrong. I am not saying you should stop taking them. What I am saying is that the way most prescriptions get written, one condition, one drug, one appointment, does not reflect the reality of what happens inside a 68-year-old body when that drug runs for 3 years alongside 4 others. The interactions, the nutrient depletions, the slow cumulative effects on arterial tissue, the subtle shifts in heart rhythm that nobody connects back to the pill that has been on the list since 2019. That is what this video is about. Before anything else, what I share here is educational information only. It is not medical advice. Do not stop, reduce, or change any medication without speaking directly to your prescribing doctor first. The risks of stopping medication without guidance can be significantly greater than the risks I am about to describe. What I want to give you today is not a reason to stop trusting your doctor. It is a set of specific, informed questions to bring to your next appointment, questions that most patients never think to ask and that most appointments never get to. I am Dr. Andrew Carter, 15 years working exclusively with adults over 60. And the pattern I see most consistently, the one that concerns me most, is not any single medication. So it is the gap between what a drug does at the dose it was tested, in the population it was studied, and what it does in practice in a 72-year-old who is also taking 4 other things, whose kidneys are processing everything 30% more slowly than they were at 50, and whose heart muscle has been working without a break for 7 decades. That gap is where the quiet damage lives. If this is your first time here, subscribe right now. Every week I bring you specific research-grounded information about what your body needs after 60. Not to alarm you, to equip you. Let me start with the biology that makes this conversation necessary. Because without understanding why aging changes how medications behave, the 5 drugs I am going to discuss will seem like isolated concerns rather than part of a larger pattern. When we are young, the liver and kidneys handle drug metabolism at full capacity. The liver breaks down most medications through enzyme systems, primarily a family of enzymes called cytochrome P450. The kidneys clear the metabolites. The whole process runs efficiently. A drug taken at 35 reaches its intended target, does its work, and is cleared on a predictable schedule. After 60, several things change simultaneously. Liver mass and blood flow to the liver decrease. Cytochrome P450 enzyme activity declines by anywhere from 20 to 40% depending on the individual. Kidney filtration rate drops on average about 1% per year after the age of 40. By 70, most adults have lost roughly 30% of their kidney filtration capacity compared to their peak, often without ever being told, because the standard creatinine test does not accurately reflect this loss in older adults with lower muscle mass. What this means in practice is that drugs stay in the body longer. They accumulate at higher concentrations, and their effects, intended and unintended, are amplified beyond what the prescribing dose was designed to produce. A drug that is completely appropriate for a 55-year-old at a given dose may be pharmacologically equivalent to a much higher dose in the same person at 72. Not because anything changed on the prescription label, because the body changed. Add to this the issue of polypharmacy, the concurrent use of 5 or more medications, which is the reality for the majority of adults over 65 in most developed countries. Each additional drug introduces the possibility of interaction. Some interactions amplify effects, some create entirely new effects that neither drug produces alone, and some deplete nutrients, vitamins, minerals, coenzymes that the cardiovascular system depends on to maintain its structural integrity and electrical function. A study published in the British Journal of Clinical Pharmacology found that the risk of a serious adverse drug reaction in older adults increased exponentially, not linearly, with each additional medication added to the regimen. 5 drugs produced a risk almost 3 times higher than 4. 6 produced a risk significantly higher than 5. The compounding is real, and for the heart, an organ that is electrically precise, metabolically demanding, and structurally unforgiving, the consequences accumulate quietly for years before they become visible. The first medication I want to discuss is one of the most widely prescribed drugs in the world, and one that has saved an enormous number of lives. I want to say that clearly at the start, because the nuance I am about to describe is not an argument against statins. It is an argument for understanding what they do beyond the mechanism they are prescribed for. Statins, the cholesterol-lowering medications, atorvastatin, rosuvastatin, simvastatin, and their equivalents, are prescribed to reduce LDL cholesterol by inhibiting an enzyme in the liver called HMG-CoA reductase. They do this effectively. The evidence for their benefit in adults with established cardiovascular disease is among the most robust in pharmacology, but HMG-CoA reductase is not only responsible for cholesterol synthesis, it is also involved in the production of a compound called coenzyme Q10, CoQ10. CoQ10 is not a supplement marketed by wellness companies. It is a molecule synthesized in every cell in the body, and it plays a fundamental role in mitochondrial energy production. Every cell that produces energy, every cell in the heart muscle, in the arterial wall, and the skeletal muscle, depends on CoQ10 as a component of the electron transport chain. Without adequate CoQ10, energy production in those cells becomes less efficient. When statins inhibit HMG-CoA reductase, they reduce the production of both cholesterol and CoQ10 simultaneously. This is not a side effect that was missed. It is a well-understood consequence of the mechanism. And multiple studies have confirmed that adults taking statins show measurable reductions in plasma CoQ10 levels, with the degree of reduction correlating with both the dose and the duration of statin use. A study published in the journal Biofactors found that adults with statin-associated myopathy, the muscle dysfunction linked to statin use, showed significantly lower CoQ10 levels than statin users without myopathy, and that CoQ10 supplementation produced meaningful improvement in symptoms in a significant proportion of those patients. The heart is a muscle. The implications are direct. The practical question to bring to your doctor is not, should I stop my statin? It is this: given how long I have been on this medication and the dose I am taking, should my CoQ10 levels be monitored? And is there a clinical reason to consider CoQ10 supplementation alongside the statin? Some cardiologists are ahead of this conversation. Many are not. Asking the question puts it on the table. If you are on a statin and you have noticed progressive fatigue, muscle heaviness, or a sense that your energy has quietly declined over the years you have been taking it, that is the mechanism worth discussing, not to stop the statin, to understand what else the body may need alongside it. Comment the word statin below right now if you have been taking one for more than 2 years and have never discussed CoQ10 with your prescribing doctor. I want to know how many people are in that situation. The second category concerns medications that most adults over 60 consider completely routine, something from the pharmacy shelf, something taken without a second thought, for a sore back, for joint pain, for the inflammation that comes with an aging body, non-steroidal anti-inflammatory drugs, NSAIDs, ibuprofen, naproxen, diclofenac, and their prescription equivalents. The cardiovascular concern with NSAIDs is not theoretical. It is mechanistic and consistent across the research literature. NSAIDs work by inhibiting the cyclooxygenase enzymes COX-1 and COX-2 that produce prostaglandins, the signaling molecules responsible for pain and inflammation. But prostaglandins also regulate several cardiovascular functions. They maintain the balance between vasoconstriction and vasodilation in the arterial wall. They modulate fluid retention in the kidneys. They influence platelet aggregation. When NSAIDs suppress prostaglandin production, they shift that balance. Blood vessels are more prone to constriction. The kidneys retain more sodium and water. Blood pressure rises, and for the COX-2 selective NSAIDs, the ones designed specifically to spare the stomach, the concern is even more direct. COX-2 is expressed in the vascular endothelium, where it produces a prostacyclin that inhibits platelet clumping and promotes vasodilation. Selective COX-2 inhibition removes that protection, leaving the platelet aggregation side of the equation unopposed and the arterial environment more prothrombotic. A meta-analysis published in The Lancet examined data from over 350 randomized trials involving more than 140,000 patients and found that all NSAIDs, including over-the-counter doses, were associated with increased risk of major cardiovascular events. The risk was highest for high-dose long-term use, but even short courses in adults with pre-existing cardiovascular risk factors produced a measurable signal, and the study specifically noted that risk was amplified in adults over 65. For adults over 60 with any cardiovascular risk factor, hypertension, previous cardiac event, diabetes, kidney disease, reaching for ibuprofen or naproxen for regular pain management is not a neutral choice. It is a cardiovascular input. For acute short-duration use, 2 or 3 days for a specific injury, the risk is relatively low. For chronic use, several days per week over months, in a 70-year-old with blood pressure already being managed, that is a conversation that needs to happen with a doctor. Acetaminophen does not share this cardiovascular mechanism and is generally the safer analgesic choice for adults over 60 with cardiovascular risk factors. The question for your doctor is this: given my cardiovascular history, is there a pain management approach that avoids regular oral NSAID use? Type yes in the comments right now if you take ibuprofen or naproxen more than twice a week and have never discussed the cardiovascular dimension of that with your doctor, because that number in the people watching this video may be larger than I expect. And if you have not yet subscribed to this channel, do it now and ring the bell, because this is the kind of information that the standard 10-minute appointment almost never reaches. I want to tell you about Richard, 73 years old, retired firefighter from Cincinnati, Ohio. He came to me after his cardiologist noticed a pattern. His blood pressure, well controlled on medication for 6 years, had gradually climbed over the previous 18 months despite no change in his antihypertensive regimen. His doctor had increased his medication dose twice, had helped modestly, but the pressure kept creeping. When I went through Richard's full medication and supplement list, something his previous appointments had not done comprehensively, I found that he had been taking naproxen nearly every day for about 2 years, not prescribed, over the counter for chronic knee pain from his years of physical work. He took it the way people take vitamins, automatically, without thinking of it as something that interacted with his heart. Naproxen had been sustaining a sodium and water retention effect that worked directly against his antihypertensive. His doctor had been chasing a blood pressure problem that had a pharmaceutical cause, one available without a prescription, that nobody had thought to ask about. We worked with his primary care physician to replace the naproxen with acetaminophen for daily pain management and added a topical diclofenac gel for the knee specifically. Topical NSAIDs have significantly less systemic absorption and a markedly reduced cardiovascular profile compared to oral versions. Within 8 weeks, his blood pressure had returned to the range it had been 2 years prior. His antihypertensive dose was reduced back to its original level. He told me I had no idea it was doing that. I told him most people do not. That is not your fault. That is a communication gap in how over-the-counter medications get discussed or do not get discussed in a standard appointment. The third medication category is one I have mentioned in other contexts on this channel, and its cardiovascular dimension is one of the least discussed in standard care. Proton pump inhibitors, PPIs, omeprazole, lansoprazole, esomeprazole, pantoprazole, PPIs are prescribed for acid reflux, GERD, stomach ulcers, and as protective agents alongside NSAIDs or blood thinners. They work by blocking the pump that produces hydrochloric acid in the stomach lining. They are highly effective at what they do, and they are among the most widely prescribed medications in adults over 60 globally. The cardiovascular concern with PPIs operates through 3 specific pathways, and most people on these medications have never heard of any of them. The first is magnesium depletion. PPIs reduce the absorption of magnesium from the gut. Magnesium is essential for cardiac electrical function. It stabilizes the membrane potential of cardiac myocytes, the cells of the heart muscle, and is a cofactor for hundreds of enzymatic reactions involved in energy production and vascular tone. Hypomagnesemia, low blood magnesium, is a recognized cause of cardiac arrhythmias, including atrial fibrillation. A study published in the American Journal of Medicine found that long-term PPI use was independently associated with hypomagnesemia and that the risk increased significantly after 1 year of continuous use. The second is B12 depletion. Stomach acid is required to release vitamin B12 from food proteins. Without adequate acid, dietary B12 is not absorbed. B12 is required for the conversion of homocysteine to methionine. When B12 is insufficient, homocysteine accumulates. Elevated homocysteine is an independent cardiovascular risk factor. It damages the endothelial lining of arteries, promotes inflammation in the vessel wall, and increases clotting tendency. A study published in JAMA found that adults taking PPIs for more than 2 years had a 65% higher risk of B12 deficiency compared to non-users, 65%, from a medication taken primarily for digestive comfort. The third pathway operates directly in the arterial wall itself. Research published in the journal Circulation found that PPIs inhibit an enzyme responsible for breaking down a compound called ADMA. ADMA directly blocks the enzyme that produces nitric oxide, the molecule responsible for arterial relaxation and blood pressure regulation. Higher ADMA levels mean less nitric oxide. Less nitric oxide means stiffer arteries and higher resting blood pressure. This mechanism is independent of any nutritional depletion. It is a direct endothelial effect. 3 separate cardiovascular pathways from a drug most people consider a simple stomach acid reducer. The conversation to have with your doctor is about duration and necessity. PPIs are among the most overprescribed medications in older adults. Many people started them for a short-term indication and have remained on them for years without reassessment. The question is not, are PPIs dangerous? It is, do I still need this at this dose? And if so, are my magnesium and B12 levels being actively monitored? Those 2 questions asked specifically open a clinical conversation that most PPI prescriptions have never had. The fourth category involves a class of medications that many people taking them do not associate with the heart at all because they were prescribed for something that seems entirely unrelated. Certain antidepressants, sleep medications, and antipsychotics, specifically the older tricyclic antidepressants, some SSRIs at higher doses, and the antipsychotic medications that are increasingly prescribed in older adults for sleep, anxiety, or on behavioral symptoms of dementia. The cardiac concern here is electrical. The heart operates on a precisely timed electrical cycle, depolarization, repolarization, the coordinated contraction of hundreds of millions of cells firing in sequence. This electrical timing is governed by ion channels in the cardiac cell membrane, channels that control the flow of sodium, potassium, and calcium in a sequence that produces the normal heartbeat. Many psychotropic medications, including tricyclic antidepressants like amitriptyline and nortriptyline, several antipsychotics including haloperidol and quetiapine, and certain antihistamines prescribed for sleep, block the cardiac potassium channel responsible for repolarization. This produces a measurable prolongation of a parameter called the QT interval on an electrocardiogram. QT prolongation, when it becomes significant, creates the conditions for a life-threatening arrhythmia called torsidez de pointes, a rapid, disorganized rhythm that can degenerate into ventricular fibrillation. The risk of QT prolongation from any individual medication is generally low in an otherwise healthy heart, but in an older adult whose heart already has structural changes from decades of cardiovascular history, mild hypertrophy, reduced electrical reserve, any degree of ischemic change, the threshold for this arrhythmia is lower, and when QT prolonging medications are combined, which happens regularly in polypharmacy situations, often without anyone specifically checking for this interaction, the risk compounds. A study published in the Journal of the American College of Cardiology found that adults over 65 on 2 or more QT prolonging medications had a significantly higher rate of sudden cardiac death compared to those on 1 or none. The interaction was not flagged by automated pharmacy systems in the majority of cases reviewed because the individual drugs were within approved dose ranges. The problem was the combination. The practical question for your doctor is straightforward. If you are on any medication for depression, anxiety, sleep, or behavioral symptoms, ask specifically whether that medication has QT prolonging effects. Ask whether any other medication in your current regimen shares that property. Ask whether an electrocardiogram has been done recently to assess your baseline QT interval. This is not a conversation about stopping antidepressants or sleep medications. It is a conversation about awareness and about ensuring that the cardiac electrical dimension of your medication regimen has been evaluated rather than assumed to be fine because each drug is within its approved range individually. I want to tell you about Dorothy, 70 years old. Retired librarian from Nashville, Tennessee. She came to me after an episode that had frightened her deeply, a sudden, racing, irregular heartbeat that lasted about 90 seconds and then resolved. Her GP had told her it was likely a benign palpitation and ordered no further investigation. Dorothy was on 3 medications, escitalopram for depression, prescribed 8 years ago, diphenhydramine, a common over-the-counter antihistamine which she took nightly for sleep, and azithromycin, a short course of antibiotics that her doctor had prescribed for a respiratory infection 2 weeks before the episode occurred. All 3 of those medications prolong the QT interval to some degree. Individually within standard doses, in a healthy heart, each is considered relatively low risk. Together, in a 70-year-old woman whose baseline cardiac electrical function had never been assessed, they had temporarily created conditions that her heart struggled to maintain stable rhythm through. We arranged an ECG and a full cardiac review. Her baseline QT interval was at the upper end of normal, which meant the combined drug effect had pushed it into a range where the arrhythmia risk became real. We worked with her psychiatrist to transition her from escitalopram to an alternative with a lower QT profile. We replaced the diphenhydramine with a different sleep approach, and we noted in her medical record that QT prolonging medications required specific caution. She told me nobody had ever told me that the antihistamine I buy at the pharmacy was a heart medication. I told her it is not marketed that way, but in the right combination, in the right person, it absolutely behaves like one. The 5th and final category does not belong to a single drug class. It belongs to a pattern, and it is the most important thing I am going to say in this entire video. Calcium channel blockers and certain diuretics, specifically the thiazide class, are prescribed millions of times each year appropriately for blood pressure management. They are effective, they are well tolerated by most people, and they are the central medications in many cardiovascular treatment regimens. But both classes, when they run long-term in aging bodies, can produce a specific and underappreciated mineral shift. Thiazide diuretics increase urinary excretion of magnesium. We have already discussed why magnesium matters for cardiac rhythm. But thiazides also increase calcium reabsorption from the kidney, and in some patients, long-term thiazide use may contribute to elevated blood calcium levels, and in the context of vitamin D deficiency or supplementation, to vascular calcium deposition. Calcium depositing in arterial walls, arterial calcification, is one of the mechanisms that drives the arterial stiffness associated with aging cardiovascular disease. Calcium channel blockers do not cause this issue directly, but they introduce their own consideration. In the context of polypharmacy, they interact with several common medications through the cytochrome P450 enzyme system. Verapamil and diltiazem in particular are potent inhibitors of CYP3A4, one of the liver's primary drug metabolizing enzymes. When these medications are present alongside statins, certain antibiotics, or other common drugs that share this metabolic pathway, the concentrations of those other drugs can rise significantly, sometimes doubling or tripling without any change in dose. This is not a rare edge case. It is a documented and clinically important interaction that is relevant every time verapamil or diltiazem is added to a regimen that already contains a statin, a specific antibiotic, or several other common medications. The CYP3A4 interaction needs to be checked specifically, deliberately by a pharmacist or physician reviewing the complete medication list. A study in the American Heart Journal found that clinically significant drug-drug interactions in older adults on cardiovascular medications were present in more than 40% of patients reviewed, and that the majority of those interactions had not been flagged in the patient's medical record. Not missed by a careless doctor. Missed because the system of individual prescriptions from individual specialists does not reliably produce a single person who is looking at the complete list and asking the right question. That person can be you. Here is what I want you to take into your next appointment. Bring your complete medication list, not the list you think your doctor has. The actual list, every prescription, every over-the-counter product, every supplement, every sleep aid, every antacid. Bring doses and how long you have been taking each one. This document is the single most valuable thing you can bring to a medical appointment, and most patients do not bring it. Ask specifically about nutrient monitoring. If you are on a statin, ask about CoQ10 and about whether your levels have been checked. If you are on a PPI, ask about magnesium and B12 and when they were last tested. If you are on a thiazide diuretic, ask about magnesium and potassium and whether calcium has been assessed recently. Ask about QT interval. If you are on any psychotropic medication, antihistamine taken regularly for sleep, or any antibiotic course, ask whether an ECG in the past year has assessed your baseline QT. Ask whether any medications in your regimen share a metabolic pathway, specifically CYP3A4, and whether a pharmacist has reviewed your complete list for interactions in the past 12 months. Many hospital systems and community pharmacies offer medication review services specifically for this purpose. It is almost never suggested unprompted. Ask for it. And ask this question, which is the most important one of all: is every medication on this list still the best option for my current situation at the current dose, given how long I've been taking it and what else is on the list? Not to start over, not to challenge your doctor, but because a prescription written in 2018 for a specific condition deserves to be reviewed in 2025 in the context of everything that has been added since. 4 things to carry away from this. The first is that aging changes pharmacology in ways that most prescriptions do not account for. The same dose in the same person 10 years later is a different pharmacological event. That gap deserves active management, not assumption. The second is that nutrient depletion is a real and specific cardiovascular risk from several of the most common medications in older adults. Magnesium, B12, CoQ10, these are not alternative medicine concerns. They are documented mechanisms, they have specific tests, and most people on long-term medication have never had those levels checked in the context of the drug they are taking. The third is that the complete medication list, everything from every prescriber, including what comes from the pharmacy shelf without a prescription, needs to be reviewed as a whole at least once a year by someone who is looking at the entire picture. The fourth is that you are not powerless in this. Knowing which questions to ask does not require a medical degree. It requires the information I have just given you and the willingness to use an appointment to ask something different from what you usually ask. Your heart has been working for you across every year and every decade of your life. It does not ask for much. But one of the things it needs, one of the things it is quietly relying on, is that the medications taken in its name are being monitored carefully enough to see what they are doing over time. You are not broken. Your medication list is not a life sentence. It is a conversation that deserves to keep happening as long and as carefully as the conditions it was written to address. Share this video with someone you know who takes 5 or more medications and has never had a single appointment dedicated to reviewing them as a complete picture. And subscribe to this channel, because every week I come here with one purpose: to give you the information that makes your next appointment more valuable than the last one. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way, take care of yourself,